So what causes, coming to the pathophysiology of pre-eclampsia, what causes pre-eclampsia? Also, what is the basic problem in pre-eclampsia? So in the middle, in the last column here, you see the normal pregnancy where the placenta is there into the myometrium of the uterus. It is deep inside, and these are the spiral arteries which are normal. So what is the problem in pre-eclampsia is this placentation is abnormal. So you see there is abnormal placentation. The placentation is itself is very shallow, and there is defective trophoblasts. So you can see a lot of trophoblasts here. The trophoblasts are poorly differentiated here in pre-eclampsia. And also regarding the spiral arteries, there is failure of remodeling of the spiral arteries. This is the main pathophysiology of pre-eclampsia, that is abnormal placentation. The placentation is shallow, there is defective trophoblast differentiation and failure of the remodeling of the spiral arteries. So what happens with this? You see here there is impaired trophoblast inflammation and spiral artery remodeling here. So this leads on to a reduced uteroplacental perfusion. So because of the reduced blood flow to the fetus, there is going to be a reduced fetal growth and iurgia and all the problems to the fetus. So there is, because of the placental hypoxemia, that is the main thing which is going to happen, that activates the systemic response. It causes increase in the intrarenal renin-angiotensin axis, and it increases sensitivity of the angiotensin II enzyme. So this used to increase sympathetic activity that cause all our systemic manifestation of eclampsia. And also this hypoxia also stimulate a lot of angiogenic and anti-angiogenic factors. These are the angiogenic and androgenic factors which are here. So there is a lot of imbalance between them that ultimately leads to reduced angiogenesis and endothelial dysfunction. And also you can see vasodilators are reduced. On the other hand, the vasoconstrictors are increased. So the basic pathophysiology is going to be a endothelial dysfunction leading to a profound vasospasm that is going to cause an end organ damage. So see, what are the end organs that are going to be affected? If you see in the lung, because of the increased systemic vascular resistance, they are more prone for pulmonary edema. Destruction of platelets causes thrombocytopenia. So if we come to the liver, it causes hepatic dysfunction and destruction of hepatocytes. The kidney, it causes proteinuria and can progress to an end-stage renal disease. Blood pressure, hypertension, and heart, it's going to have a left ventricular hypertrophy and cardiomyopathy. And the brain, it can have edemas, seizures, headaches, visual disturbances, and press. All these features can happen in pre-eclampsia. So this is regarding the clinical features. So hypertension, why there is hypertension? Because as we saw, there is increased systemic vascular resistance and afterload. There is decreased cardiac output. Despite high pressures, the intravascular volumes are low in the patient of eclampsia. This should pre-eclampsia. This should be considered while fluid restricting the patient with pre-eclampsia. There is imbalance between the vasoconstrictors and vasodilators. So the vasoconstrictor take the upper hand. So this can lead to clinical consequences like heart failure, pulmonary edema, renal dysfunction, and neurological injury. Coming to the kidney, there's going to be proteinuria. This is because of glomerular endotheliosis. So because there is increased tubular permeability, there is going to be proteinuria. So this can lead to hypertension and can progress to a chronic kidney disease. Neurological abnormalities, pre-eclampsia causes sudden surges in blood pressure that can breach the blood-brain barrier, and there can be sudden vasogenic edema. So patient can present with headache, visual disturbances, retinopathy, retinal detachment, a sort of cortical blindness, hypertensive retinopathy. These are quite common in these patients. So clinically they manifest as seizures, radiologically as press, which we will be seeing in the coming slides. And again, cardiac dysfunction, we have increased SVR and afterload, cardiac LV, concentric LV hypertrophy. So they are more prone for heart failure and peripartum cardiomyopathy. Pulmonary edema can occur because of increased vascular permeability, and patient, if given more volume, hydrogenic volume overload, can lead to a pulmonary edema that can precipitate acute hypoxemic respiratory failure. Hepatic dysfunction, again it causes hepatic microcirculatory deterioration and hepatocellular injury. So clinically we can see it as raised transaminases, and in extreme cases the hepatic failure can be so bad that Gleason's capsule can give way, the patient can die of a hepatic rupture and hematoma. Hematological dysfunction, it is a procoagulant state. There is going to be a thrombocytopenia and DIC is common. Fetal growth restriction because of the reduced intrauterine, the uterine and placental dysfunction.